Hello, my name is Jan Leifman, and I'm the director of the Immunology Division of the Global COVID Task Force. Today, I'll be speaking to you about from COVID-19 to Covi-Flu, diving into the immunological paradigm. So, the presentation will have the following overview. First, I'll begin with the clinical presentations of SARS-CoV-2. Then, I'll transition to our proposed SARS-CoV-2 and Covi-Flu models. Next, I'll describe cellular therapies, specifically mesenchymal stem cells. Subsequently, I'll speak about additional cellular therapies under investigation. And then I'll discuss how to prevent Covi-Flu. So first, let's discuss the clinical presentations of SARS-CoV-2. So COVID-19 is a respiratory illness, and that's really caused by the novel beta coronavirus SARS-CoV-2. And its rapid spread has caused a global pandemic. Now, this viral infection has broad symptomatic presentations that affect most of the organs within the body. And that is really illustrated here. It affects the lungs, the liver, the kidneys, the brain, the eyes, the nose, and then the vasculature along with the heart. Now, shown here are the most common clinical presentations of COVID-19, where flu-like symptoms tend to predominate. And that's evident by fever, cough, fatigue. But SARS-CoV-2 is unique because it also causes some non-specific symptoms like loss of smell and loss of taste. The spectrum of this condition is wide, as the condition can range anywhere from asymptomatic disease all the way to critical illness, which may result in multi-organ failure, especially in critical disease, along with acute respiratory distress syndrome, sepsis, and shock. Now, the clinical manifestations of severe COVID-19 are varied, and they themselves can present as those listed on the slide. It can present as acute respiratory distress syndrome, acute cardiac injury leading to arrhythmias and cardiomyopathy, acute kidney injury, neurological disorders, and then hypercoagulability leading to thromboemboli, including pulmonary emboli and strokes. Now, taking into account this diverse clinical presentation really begs the question, is there some kind of model that can tie all of this together and explain it all? And so herein we'll discuss the models that our group proposed. So first, I want to present our proposed model for SARS-CoV-2. Now, in this model, SARS-CoV-2 acts via a direct and an indirect mechanism to induce damage. First, looking at the direct pathway, you have the virus binding to the H2 receptor on all of the organs listed here. In each of them, you have invasion, replication, and damage. And then from the lungs, you have increased secretion of IL-6, which then goes into your indirect pathway, which I'll speak about in a few minutes. Now, in each of the organs shown here, you have the associated damage that results. So, looking at the nose, you have anosmia, which is loss of smell. In the heart, you have a diverse clinical presentations that can present as myocardial infarctions or heart attacks, cardiac inflammation, atherosclerosis, hypertension. You have thrombosis in the blood vessels. You have acute kidney injury or kidney failure in the kidneys. In the brain, you can have altered mental status, you can have stroke, you can have seizures, you can have brain inflammation. And then in the liver, you have hepatic injury. Now, going into your indirect pathway, you have the virus activating antigen presenting cells, which are macrophages, dendritic cells, or monocytes. And then that leads to downstream secretion of IL-6. You have IL-6 coming from your direct pathway. You have the virus stimulating pulmonary macrophages, which leads to increased secretion of IL-6, which then increased secretion of IL-1, which then causes increased secretion of IL-6 downstream. And then hypoxia, which tends to result either from an underlying medical condition or prolonged SARS-CoV-2 causes hypoxia, and then that causes increased secretion of IL-6. Now, IL-10 is supposed to rein in your IL-6, but because you have so much more IL-6, like a seesaw, your IL-10 is unable to rein it in. IL-6 builds up and activates these downstream pathways. So via cis signaling, you have stimulation of lymphocytes, which then promote your pro-inflammatory pathways and downregulate your anti-inflammatory pathways. In the liver, you have increased buildup of acute phase reactants, thrombopoiesis, complement, and decrease in albumin. And then in the vasculature, you have promotion of leakiness, increased permeability, and then recruitment of neutrophils and monocytes. And all of this together is a cytokine release syndrome, which then causes inflammatory damage. So the analogy that I like to use is if you have a person standing in the middle of the road, you have a bus hitting them from the front, which is your direct pathway, a bus hitting them from the back, which is your indirect pathway. And in essence, that is what causes the systemic injury. Now, during the course of our research, we also discovered a potential synergism between influenza and SARS-CoV-2. Now, within this model, essentially, you have simultaneous infection with both viruses that will lead to a further increase in IL-6 production, which will then lead to more widespread systemic inflammation and injury than infection with either of the viruses alone. So when you look at your direct pathway, you have SARS-CoV-2 once again binding to your ACE2 receptor and affecting all of the organs shown here. Now we put the lungs front and center because that is the interplay between both SARS-CoV-2 and influenza. And then also you have secretion of IL-6. When you have influenza binding to SA glycoproteins, which are specific receptors, you also have invasion, replication, and damage in the lungs, and then you have even more increase in IL-6. And this IL-6 goes similarly into your indirect pathway. When you look at the indirect pathway, you have SARS-CoV-2 binding via PAMPs and DAMPs, which are non-specific receptor, activating antigen-presenting cells, which then secrete IL-6. You have hypoxia promoting increased IL-6. You have IL-6 coming from your direct pathway. You also have then influenza via PAMPs and DAMPs, activating pulmonary macrophages, and then secreting either IL-6 directly or increasing IL-1, which then downstream increases IL-6. Once again, your IL-10 is unable to rein in your IL-6, and so as a result, this causes a buildup in IL-6, activating similar downstream pathways, resulting in a cytokine release syndrome, leading to systemic inflammatory injury. Now, most of the publications in the literature refer to the cytokine response caused by SARS-CoV-2 as a cytokine storm. But this term was originally coined as a key side effect of CAR T-cell therapy. So I want to take this time to briefly compare and contrast the cytokine storm in CAR T-cell therapy with the upregulated cytokine release syndrome in SARS-CoV-2. So when you look at time, the cytokine release syndrome in SARS-CoV-2 is much slower. It occurs in days, as compared to the cytokine storm in CAR T-cell therapy, which is acute onset occurring within hours. When you look at clinical features, they're vastly different because the cytokine storm in CAR T-cell therapy leads to capillary leak, neurotoxicity, and hypotension, as compared to cytokine release syndrome in SARS-CoV-2 being more along the lines of influenza-like syndrome with late manifestations of DIC and multi-organ damage. The cytokine profile is 10 to 100-fold higher in cytokine storm and CAR T-cell therapy as compared to that in SARS-CoV-2. And then the causes of death are vastly different, as they are status epilepticus or distributive shock in cytokine storm in CAR T cell therapy versus that of respiratory failure in cytokine release syndrome in SARS-CoV-2. And thus, they are two totally different entities with large variability in presentation. So now let's discuss therapeutic interventions. Now, currently, there are limited efficacious therapeutic interventions against severe SARS-CoV-2 or Covi-Flu for that matter. Based on the similarities between the disease mechanisms of SARS-CoV-2 and influenza virus, we really propose the idea of a combination therapy that can somehow control the systemic inflammation induced by both viruses, as this approach has a much higher likelihood of inhibiting the pro-inflammatory pathway at multiple points in the indirect pathway. Now, one promising approach is a cellular therapy. And this therapy uses mesenchymal stem cells that has yielded promising preliminary efficacy in COVID-19 patients. And here we show 3 companies that have used these cells in patients and shown similar efficacy. Now, one of these companies, Plurigstem, did a 28-day follow-up from their early phase clinical trial in 7 patients with multi-organ damage. And all of them made a successful recovery shortly after mesenchymal stem cell treatment. Now, this recovery persisted even at the 28-day mark, and all the patients remain COVID-free. The company received FDA approval for a phase 2 clinical trial for this treatment of 140 patients with severe COVID-19 and ARDS. Now, I know what you're thinking. How? How does this therapy work, and why? Why is it so effective? So, mesenchymal stem cells, they act as immunomodulators, where they're able to downregulate the pro-inflammatory and upregulate the anti-inflammatory pathways. Now, recent studies have shown that they also possess antiviral activity as well. Additionally, they also have effects on all of the cells shown here. So when you look at macrophages, there are 2 types. There are M2 macrophages, which promote and upregulate anti-inflammatory pathways, and then there are M1 macrophages, which downregulate pro-inflammatory pathways. So mesenchymal stem cell therapy shifts the macrophage profile towards more of the M2 macrophages, activating anti-inflammatory pathways, downregulating the inflammation, while decreasing the M1 macrophages. They also decrease dendritic cells, which are responsible for pro-inflammatory cytokine release, decreasing natural killer cells, which decreases cytotoxicity, and then decreases B and T cells as well. In essence, they're like a reset switch for the immune system. So, when applied to our proposed model for both SARS-CoV-2 and of Covi-Flu, mesenchymal stem cells should inhibit IL-6 at multiple points within the indirect pathway by decreasing IL-1 and increasing IL-10. And then this can further act to dampen IL-6 expression, decreasing pro-inflammatory and increasing Tregs. So looking here, you see that that mesenchymal stem cells act along the pathway at all points simultaneously, basically the big roads and the small roads, so to speak, to make an analogy, blocking IL-6. And that is shown here, and that is shown here. But they also act to block IL-1, which then decreases the ability to stimulate downstream upregulation of IL-6 secretion. And they also increase IL-10. And thus, by increasing your IL-10 is now able to much better rein in your IL-6, decreasing IL-6 further. So in essence, this decrease in IL-6 decreases its ability to activate these downstream pathways, thereby decreasing the cytokine release syndrome, and thus decreasing systemic inflammatory injury. Now, shown here is a pictorial schematic of the effects of these cells within the alveoli. Mesenchymal stem cells are allogeneic, and they can be derived from several sources, including the bone marrow, adipose tissue, and the umbilical cord. and also placenta as well. They're expanded and then infused into patients, and they act systemically where they can reach the lungs, where they redirect immune response that favors the dampening of inflammation to promote recovery and decrease mortality. And that is shown here pictorially, where once mesenchymal stem cells are infused into the patient, they go into the lungs. This is your damaged alveoli. So what they do is they redirect your T cell response. They switch or convert the macrophages from M1 to M2, which a few slides ago were responsible for promoting anti-inflammatory pathways. And then they also turn on your anti-inflammatory cytokines. And this promotes recovery, whereby you now have reduced inflammation, a recovery and an increase in pulmonary function, and a decrease in mortality. Now, most recently, one of these companies, Mesoblast, has demonstrated promising results from their phase 3 clinical trial and received fast track designation from the FDA. Bonus Bio's Mesenchyr is another promising mesenchymal stem cell therapy that has demonstrated promising efficacy in phase 2 clinical trials that is now expanding to a phase 3. Now, what makes this product unique is that it, unlike the others, uses fat as its source. Now, the efficacy of these cells was further verified in a double-blind, randomized, controlled clinical trial performed by the University of Miami. This trial was designed to really assess the safety and explore the efficacy endpoints of allogeneic umbilical cord mesenchymal stem cells in patients with COVID-19 and ARDS. So in this study, they had 24 patients with COVID-19. Mesenchymal stem cells from the umbilical cord were derived and then expanded in a bioreactor and then cryopreserved until a patient was available. They were then prepared for IV injection, and each patient received 2 IV infusions, 72 hours apart, 100 million cells each time. And this is the inclusion criteria. And I only show this just for completeness sake. So a patient had to have been hospitalized for COVID-19. They had to be of an age 18 years or more, willing to participate in the study, have a peripheral capillary oxygen level of 94% or less at room air. They had to have a PaO2 to FiO2 ratio of less than 300, which clinically is diagnostic for ARDS. And then they had to have bilateral infiltrates on chest radiograph or ground glass opacities on chest CT. So the primary endpoint was safety, and that was achieved where no serious adverse events were noted post mesenchymal stem cell infusion. And so this therapy was really shown to be safe. Now, when they did treatments, and just to make sure everyone's on the same page, the green line represents the group treated with mesenchymal stem cells, and the orange represents the control group treated with standard therapies available at that time. So when they looked at these patients, after 30 days, 91% of them survived who received mesenchymal stem cells compared to 42% in the control group. By day 30, patients who were treated with mesenchymal stem cells demonstrated improved time to recovery. And then when looking at survival by day 30, 100%, yes, 100% of patients less than the age of 85 survived. And this continued even at the 3-month mark, where mesenchymal stem cell treated patients did better than control, as evident here. They also did a cytokine analysis at day 0, which was defined as right before mesenchymal stem cell infusion, and at day 6. And they observed statistically significant decreases in pro-inflammatory cytokines, chemokines, and growth factors that were involved in cytokine release syndrome post-MSC therapy. Now, that is really shown here where this shows day 0 right before treatment and then day 6 several days after treatment. And as you can see in each of the cytokines shown here, there's a significant decrease in the group treated with MSC therapy for IL-2, IL-5, IL-6, IL-7, TNF alpha, TNF beta, etc., etc. But the cytokine testing was limited as they did not do a full panel. For example, IL-10, which is a prominent feature in the model that we proposed, was not really tested. So MSC therapy was found to be safe. No subject suffered any serious adverse events who had undergone MSC therapy. And then MSC therapy reduced the production of inflammatory cytokines. MSC therapy was associated with improved patient survival and time to recover. So now let's discuss additional cellular therapies under investigation. Now, a clinical study performed by Johns Hopkins in July of 2020 showed promise when allogeneic T regulatory cells, or Tregs for short, derived from cord blood successfully downregulate systemic inflammation in 2 critically ill patients with SARS-CoV-2. Now, the critically ill patients were aged 69 and 47, and they had multi-organ failure. They had been treated with therapies that included tocilizumab, hydroxychloroquine, broad-spectrum antibiotics, and vasopressors as well, along with inhaled nitric oxide. The older patient received 2 compassionate use infusions of Tregs at days 13 and 17 of his hospital stay, while the younger one received 3 infusions on day 8, day 11, and day 15. Both patients showed clinical improvement in reduced inflammatory markers within days of their first infusion with the immune cell-mediated product, and no infusion reactions, inflammatory rebounds, or other adverse effects were really seen. These individuals were extubated, but they also needed tracheostomies. Now, the promising results of the study will result in a multi-center randomized trial, which will compare multiple doses of this potential promising cell therapy with placebo amongst intubated patients with COVID-19 ARDS. So now let's discuss natural killer cell therapy. Natural killer cells, so they play a prominent role in mediating the innate immune response, and studies have shown that NK cell depletion was associated with a higher onset of viral infections. Studies have shown that SARS-CoV-2 infection was associated with fewer blood NK cells, but a higher activation state in circulating NK cells. Now, in the study shown on the slide, NK cell levels and activity was impaired in severe COVID-19 patients, and that is really shown here by these graphs. Now, one group hypothesized that potential interaction between SARS-CoV-2 and NK cells. And so I want to first point your direction to the right, where in the case of effective immune response, NK cells express activation marker CD107A, and they release interferon gamma, IL-2, and TNF alpha, and thus they're promoting a pro-inflammatory state with the potential to combat the virus. When you look on the left, over time, these cells become exhausted. And when this does happen, NK cells overexpress the inhibitory receptor NKG2A, which suppresses T cell and NK cytotoxic function, favoring a systemic pro-inflammatory condition, but an inability to combat the virus. Now, seeing the potential of this therapy, several companies have invested in developing allogeneic NK cells. Fate Therapeutics has repurposed their induced protein-derived NK cell product, initially for AML and lymphoma, to combat coronavirus, and they believe that these genetically engineered NK cells can diminish viral replication. A clinical trial is currently underway at the University of Minnesota. So let's discuss the prevention of Covi-Flu. Flu season is upon us, and Covi-Flu is a burgeoning pandemic. In anticipation of this, we propose a preventative approach that can be implemented now so that we may be better prepared for what may come. And the solution is really simple. Get a flu shot. Last year, or actually a year and a half ago, we were actually amongst the first in the world in our publication to speak about Covi-Flu, show its mechanism, and really get ahead of the game in terms of making this proposal. And so we suggested that getting the flu shot was the most effective means of prevention and protection at the time. And the hope is really that the flu shot would provide immunity against influenza and thereby decrease a synergism of the two viruses. And so by keeping the flu at bay, we can then focus on attaining better control of SARS-CoV-2 with the promising therapies and vaccines currently in clinical trials. Now, the question, this obviously begs the question, should we even get vaccinated? And recent studies over the past few months have shown the answer is actually yes. And so in both of these studies shown here, it was shown that influenza vaccination is associated with a lower risk of SARS-CoV-2 infection. And also reduction in the odds of developing severe COVID-19. Now, the next question was, is co-administering the flu and the COVID vaccine safe? And the answer is yes. And that is shown in both of these studies released over the past few months that really have shown that it is safe, really no significant difference in adverse events, and no difference in the levels of antibodies elicited between the two cohorts. So in conclusion, we proposed a cohesive mechanism of action for SARS-CoV-2 and presented the first synergistic paradigm between influenza and SARS-CoV-2, which we termed as Covi-Flu, along with models and therapeutic interventions for both. Now, looking forward, we see combinational therapies being used that can better thwart the virus's heterogeneity, mutational adaptations, and also block multiple inflammatory pathways simultaneously, and thereby reducing systemic inflammatory damage. Now, based on our model, we feel that enacting a flu immunization program can provide some protection against the synergism of the two viruses until a more robust and definitive therapy is devised. And that was further supported by recent clinical studies. Now, success can only be achieved through great mentorship. And I was fortunate to have worked with a great team. I'm blessed for the mentorship that I'd received from Dr. Sharma and Dr. Chaudhry, and it was a pleasure to work and learn from everyone on the global COVID-19 task force.